And the next lecture is lecture of Professor Rudy Nuїtс, past president of the ESCRS and director of clinic in Maastricht, Holland.
Good afternoon. My name is these are my financial disclosures. I'm an ophthalmologist from the University Eye Clinic Maastricht in the Netherlands, and I feel extremely honored to have been invited by the Ukrainian Ophthalmic Society of Ophthalmic Surgeons to give this presentation for you today in these very difficult times for the Ukrainian people. I'm a little bit bothered by COVID at the moment. That's the reason why I thought it probably would be better to send it to you pre-recorded instead of listening to the coughing all the time, etc. So what I would like to speak about is cataract and corneal disease. These are my financial disclosures. And if you look at the magnitude of scale of corneal transplantations and cataract surgery in the Netherlands, you can see that we perform annually around 1,700 to 1,800 transplants and around 180,000 cataracts. So basically for every corneal transplant, we do 100 cataract surgeries in the Netherlands, so 100 times as many, to put it into perspective. Looking at endothelial transplantation in the Netherlands, you can see that we have seen a shift over the years from our registry study and data. You can clearly see that here in the graph that from 2015 to 2016-17 actually there was an explosion of DMEC, increased by 400%, and at the same time PK going down, and also DSEC actually decreasing. So now we are almost at the, let's say, equal levels of DSEC and DMEC in our country. Indications for corneal transplantation from a European perspective that has been listed by my fellow corneal surgeon, Maastricht Mo Dickman. It's still Fuchs that is the most common indication for corneal transplantation, followed by graft failure, pseudophakic bullous keratopathy, and then keratoconus, and then infection and trauma. Now, what are you going to do in those cases where we have cataract and corneal disease? And then we are talking about corneal disease, mostly about Fuchs endothelial dystrophy. The question here is it going to be a stage procedure or a triple procedure? And how do you make an appropriate selection for this choice? Well, first of all, of course, you have to know the primary cause of vision loss. Is it the cataract or is it the Fuchs? And then you have to decide which procedure. You're going to do the cataract surgery alone? If yes, how do you prevent post-op corneal decompensation? Or are you going to do the cataract surgery and followed then by endothelial keratoplasty, a so-called sequential procedure? And then, of course, you can do both at the same time, what we call a triple procedure. The indications for stage procedure or triple can be based on the preoperative corneal thickness, on early morning decompensation, so diurnal shift that is present, the level of endothelial disease that you can see at the slit lamp, the firmness of the cataract. If you have a very hard cataract, of course, the endothelial trauma will be much more severe, and the quality of vision measurement. We use quite often straight light measurements to point out the quality of vision deterioration for the patient, while the visual acuity in those instances sometimes is still very good. Looking at folks with cataract and going for the treatment strategy of a phaco with endothelial keratoplasty, the question is a triple or not a triple. So in these cases, there is a classical paper of Zeitzman. And in this paper, actually, they try to find the cutoff level of corneal thickness, which was a threshold actually for advising a triple procedure instead of a sequential procedure or doing phaco alone. And the advice here, if you look at the graph, the stripes here are the decompensated corneas. The advice here was that triple, whenever there is epithelial edema present preoperatively at the slit lamp, or when the preoperative pachymetry is more than 640 microns. Now, this is a classical paper actually, and since then other papers have appeared in the literature. And this is a very nice paper actually from Sanjay Patel, who looked at time fluke measurements, and he came up with the assessment of Fuchs at the slit lamp, and actually categorized then corneal edema into three categories, with a clinically definite edema, suspicious for subclinical edema, and no clinical suspicion. And then he looked at the topography maps, and what you saw there were three parameters actually that make you a little bit aware of potential risk for decompensation. And one is the displacement of the thinnest point of the cornea, as you can see here, toward the, I think in this case, temporal side. Then the loss of parallel and circular isopex lines. So you see here not the classical pattern of round or oval lines, but it is a little bit bumpy. And then a focal area of posterior surface depression. So you can see here minus 29. So there is a depression, so a thickening towards the anterior chamber. And by using these three specific tomographic features, he could see that these were all present in Fuchs corneas with clinically definite edema. They were present in 81% of the corneas with suspicious subclinical edema, and in 42% of the corneas without edema. So his conclusion actually was that the risk classification is independent of corneal thickness and should be considered when you're going to evaluate Fuchs endothelial disease eyes for cataract surgery, or combine it with endothelial keratoplasty. So this can help you. When can you do a phaco without endothelial keratoplasty, and what should be your treatment strategy? Well, of course, you have to look at the risk factors for endothelial cell loss. That can be, of course, based on the firmness and the size of the nucleus. You have to look at the infusion volume. That can give you more endothelial cell loss. Eyes with a shorter axial length are at risk of more edema, longer phaco time. Capsular break or vitreous loss, of course, are also bigger risk factors for endothelial edema. But most importantly, of course, you have to discuss the risk of decompensation with the patient preoperatively, because that's the most important thing that you can do. If a patient has a decompensation postoperatively and you have not discussed it preoperatively, you really get in an uncomfortable situation. There is some research that has looked at the protection of different various viscoelastics, comparing cohesive versus dispersive viscoelastics or combinations. And this is work from Arshanov and Miyata, and they compared hyalon versus a mixture of viscose and hyalon. And actually what I saw is that at day one, you can see that there is an advantage, which means that there is a less increase in corneal thickness in the eyes that have the combination of viscose hyalon versus hyalon. But this disappears already after 1 week. So it's only very temporary. This is another paper actually comparing soft shell technique of viscose hyalon versus hyalon. And you can basically see that at day 1 and at month 6, there is a less increase in corneal thickness for the group that uses the soft shell technique. Some time ago, we evaluated the effect of phaco technology on the risk for decompensation in Fuchs patients. So in a randomized clinical trial, we compared longitudinal versus torsional phaco, and what we saw is that using torsional phaco, US time is 36% lower and CDE 53% lower, especially in lenses with density grade higher as 3. We found that the only significant predictor of needing DSEC surgery post-op was the preoperative central corneal thickness. So the type of phaco technology that was used was not predictive of the risk for corneal decompensation. We also came up with this prediction model of decompensation on the right side of the slide, and you can see that for a CCT of 620 micron, this corresponds to an odds ratio of 1. But for each additional increase in central corneal thickness of 10 micron, you get an odds ratio of additionally 1.7. So if you have a 630 cornea, you have 1.7 times risk of getting a decompensation after phaco. What are the advantages of a sequential procedure? So cataract surgery followed by EK later. Well, you have a more stable lens iris diaphragm, so that makes the endokeratoplasty much easier. There is less loss during the learning curve of a beginning surgeon, but you have to be aware that you have to do some debridement sometimes of the epithelium in severe cases. In the triple procedure, so where you do phaco together with endothelial keratoplasty, the advantage obviously is that it's only one surgical procedure. You have to be aware of a couple of tips. So you have to make a smaller CCC, capsular rhexis, to keep the lens in the capsular bag so that it doesn't flip out during the surgery. You have a less stable iris lens diaphragm, as I said, and sometimes there can be some visibility issues. What do we see post-operatively? Well, you have a hyperopic effect of the graft thickness because the graft is thicker in the periphery and thinner in the center. You get a kind of a hyperopic effect on the refraction. There may also be some variability in the improvement of visual acuity, probably due to some haze at the interface that gradually fades away after months to years. And as you know, for all keratoplasty technologies, there is a continuing loss of endothelial cells also after DSIC. And the incidence of graft rejection is around 7 to 9%. Terry then came with this article that he called the new triple technique. When you use phaco together with endothelial keratoplasty, these were the first 225 eyes, and you can see quite very good results, 90% better than 0.5 visual acuity. Endothelial cell loss after 6 months, 30%, and dislocations were only 1.8% and no primary graft failures. So the conclusion from comparing DSIC with traditional perforating keratoplasty was that it induces less corneal change, the name is a more precise lens power calculation, and the refractive outcome is much more predictable. The next question then that came up is whether thinner grafts give better visual acuity. So traditionally DSIC graph was around 200 microns, and ultra-thin DSIC grafts are supposed to be around 100 microns. So this is a randomized clinical trial performed in the Netherlands by Maud Dickman, and what we show there is that if you look at the primary outcome being best corrected visual acuity, 12 months, you can see that ultra-thin DSIC is almost one Snellen line better in terms of vision as compared to a traditional DSIC. Graft dislocation was not different, 15 versus 16% in both groups. Here you can see the difference in visual acuity. So along the course 3, 6, and 12 months, you can see that ultra-thin DSIC is still around one line better as compared to traditional DSIC. And then the other question that came up over the years is DMAC really better than ultra-thin DSIC? Now we know what the advantages of phaco with DMAC are. There is a presumed better visual acuity. There is less rejection because the amount of tissue that you transplant with available cells is much lower as compared to traditional penetrating keratoplasty, and even as compared to traditional DSIC. But there are disadvantages of phaco with DMIC. There is certainly a learning curve. You have to handle an unstable anterior chamber. You need to create a smaller rhexis, which can give you some difficulties in the phaco procedure. And there might be more dislocations because you have to be very careful to remove all the viscoelastic behind the lens during the phaco and after the phaco procedure. This is an example of a phaco-DMIC procedure where you can see how I remove here the capsular rhexis. Then we do the hydrodissection. Lens turns around quite easily. We do the classical divide and conquer technique in this patient. Remove the quadrants of the lens. Removing of the cortex with bimanual INA technology. And then we implant the lens. I like to use hydrophobic acrylic lenses, which in small very softly and can be placed quite easily through a smaller rhexis. Be careful to remove everything behind the lens as you saw there. put in some myostat here, and then we do the decimeter axis. So we make quite a large decimeter axis, around 10 millimeters, and then we scrape with the Price decimeter axis forceps. We scrape the decimeter away from the cornea, remove it with this McPherson forceps, and then of course you need to remove meticulously all viscoelastic as to avoid to have some of the remnants in the eye. We hydrate the side ports, and then we prepare the decimeter DMEC graft, as you can see here. So we get it from the bank where it is already pre-stripped, only at the hinge where it is attached. Then it goes into the eye using a goiter, cannula, and a 2.8 millimeter incision. We inflate here the side port, and then by the usual tapping technology, making the anterior chamber a little bit undeep, and very carefully looking at the unfolding direction of the graft. We unfold the graft, as you can see here, until it is in its correct position. And we deflate the anterior chamber a little bit to have the edges of the lens of the graft curl towards the right position, and put in SF6 20% bevel. We prefer to use SF6 20% since we believe it stays better in the eye. It's, I think, not completely clear from the evidence in the literature if it gives less dislocation as compared to using air, but nevertheless it's our preferred way of putting the graft in position. We also use intraoperative OCT we have used that for a while. I must honestly say that we don't believe that it is of any additional benefit actually using this if you are an experienced DMEC surgeon. Looking at outcomes between ultra-thin DSEG and DMEC, this is a randomized trial from the United States, from Chamberlain, who basically showed that when you compare visual acuity after DMEC and ultra-thin DSEG, DMEC is 1.8 lines better visual acuity. He also looked at the complications after both technologies, and what he said is there is no difference in complication between both groups. But if you look meticulously at the amount of rebubblings, you can see that in the ultra-thin DSEG group there was 1 rebubbling, while in the DMEC group there were 6 rebubblings. So I think there is some difference in these two technologies. We performed a randomized clinical trial of ultra-thin DSEG versus DMEC in the Netherlands some years ago, and what we found is that there is almost one sneller line difference being in the advantage of DMEC versus DSEG. You can see that here. So over the course of after the surgery, DMEC is a little bit better, so 0.07 better in terms of LogMAR visual acuity. But what was the most distinct difference is that especially achieving higher levels of visual acuity occurs much more often in patients after DMEC in blue here as compared to ultra-thin DSEG in green. So having a vision of 1.0 actually occurs in roughly a quarter of patients with DMEC versus only 4 to 8% of the patients with ultra-thin DSEG. Looking at the circle equivalent, you can see that for both techniques there is a hyperopic shift, being much more pronounced, almost half diopter for ultra-thin DSEG versus 0.25 over diopter of DMEC. So you have to take that into account for your lens calculation. Endothelial cell density was no difference between the two groups after 12 months. And in terms of rebubbling, we also saw that there were more rebubblings with DMEC as compared to ultra-thin DSEG. So better vision, but also a little more chance for rebubbling. There are some older papers here from the group of Friedrich Kruse, and at the time also Björn Bachmann and Klaus Kosiven were co-authors here. So this is phaco with DMEC. You can see a good increase of best corrected visual acuity from 0.6 to 0.2 LogMAR visual acuity over 6 months. And if you look at the spherical equivalent also in this group, of course, there was a distinct shift, hyperopic shift of almost 0.75 diopters, so even a little bit more than what we have found. But look at the rebubbling rates, quite high. One injection afterwards in almost 60% of cases. That's a little bit less in our current experience, but it's still around 25 to 30%. Can you combine phacoedemic with toric IOL technology according to this early paper here in 10 patients? Yes, you can. I mean, the prediction of the outcome is a little bit less accurate as compared to a normal surgery, but you can see that there, if you look at the vector plots here in the centroids, the post-operative position of the centroid is much better as compared to pre-operatively. There were 4 of the 10 eyes that had some overcorrection, but that's probably also due to the fact that the first generation lens formulas were used. So what can you take home from this lecture in terms of recommendations? The indication for a triple procedure or sequential surgery should be based on the severity of the endothelial disease and the cataract. Take care to take under consideration the hyperopic shift when you're doing DSEC and DMEC. So roughly half to 0.75 for DSEC and a quarter for DMEC. Beware that the rebubbling rates are variable between studies, but there is, I think, certainly an indication that the rates are higher with DMEC as compared to DSEC. And we now have an ESCRS study headed by Björn Bachmann in progress, who's going to look at one of these outcomes in the future. Do not use hydrophilic IOLs because of the risk for IOL calcification when you're using gas or air. And you have to bring your intraocular pressure under control before you're going to do endothelial keratoplasty. So what can I wish you? I mean, this is a slide that I used when I was president of ESCRS in 2021. And we were full in the corona era, as I am today, as you can hear. This was an artist of living next to me, and he said, you know, there will be some sunshine here after all these dark clouds of corona. What I can only wish you is that there will be some sunshine for you after the terrible experience that you've been gone through after the last year, and I really wish you in that all kinds of courage and all the best, and I thank you very much for your kind attention.
Rudy Nуїтс, for your words and for your wishes for us, and sure for your experience of management of such complicated patients.